All right. Good afternoon, everyone. Welcome to the presidential plenary for this afternoon. Complex problems, multi-level methodology, and SSWR's future. So, imagine with me for a second. Imagine this. Imagine the communities that surround your academic home and institutions. Imagine if you're living in Baltimore, or you're in West Philadelphia, or you are in St. Louis. No matter where you are, imagine if those communities have problems that does not include poverty. Imagine those communities if they don't have problems like high infant mortality. Imagine if you didn't have to do work and research related to whether it is poor access to high quality food, food insufficiency. Imagine that you're waking up every day saying, what will I work on? And it does not include those sort of examples. Today's plenary will focus, as Michael has said in his brief address, what if we were testing solutions? But imagine testing solutions that produce that level of scale, that scale level impact. Can we do such things? Have we done such things? If so, how did we do it? Can we replicate such things? Imagine if that is the focus of what a good part of the Society for Social Work and Research conferences are dealing with and saying, what's next? What is the next big thing, solution that we're going to help to solve? That doesn't mean we don't do other things, but imagine that we're helping to create that reality. Imagine we're a part of that solution. Imagine that we are called upon by community, local leadership, national leadership, because that's what our profession does, and we do it well. Today's plenary, again, centers on complex problems, multi-level methodology, and SSWR's future. We will focus on looking at how social work through a futures framework can increase our impact on complex social problems by advancing new ideas about the design and analytical approach of multi-level interventions. Scholarly approaches that take an anti-racist pedagogical approach that would be appropriate for guiding our study aims and hopefully leading to effective structural interventions that tackle the social determinants not only of health, but inequality. I'm hoping we will take this time, just this brief hour, to even imagine that. And again, that the impact is at a population level. Let me make sure I'm being very clear about what I'm talking about. That the impact is not that you impact populations. The impact is at a population level. That means if there's 50,000 individuals or children who die from infant mortality for that geographic space, that we help to eliminate or bring it down to near zero. Why do I take this approach and ask you to consider that in this humble space that I have for this period of time in this role? I was just tired. I was tired of being the second and third generation of the individual scholars that I knew who were tackling the same issue now in the next generation. I remember Stephen Rose, and I told you about this yesterday, when he said, Sean, the job of social workers is to put themselves out of business. Some will say that's too grand. I don't think so. I remember one of our policy speakers and panelists says, and her dad told her, "Stop thinking you have so much time." Why do you think you have so much time? Why do we think we have so much time? Right? That we want to wait another 30, 40 years. In our profession, when we have the mindset, the skill set, the capacity, and increasing use of technology to say there is a different future that we can help occasion. That it's not easy work. As Michael said, social workers, our work is always uphill. But we can do that because I think our profession not only is prepared now to think that big, our schools are prepared to try to distinguish themselves in that way, and we're ready to think through what the theory is, what the multi-level intervention methodology is required, what innovations and analysis we have to advance in order to do that complex work. So today's session will begin to focus us in that direction, and we have wonderful people to get us started. That doesn't mean this is the first time you've heard this or some aspect of what we're talking about, but now as a professional society, we can begin to say how we are consciously focusing and making sure that our workshops, our dialogue lead to these sort of outcomes. So today we have Dr. Laura Nissen, professor at Portland State University, School of Social Work, PI, and a national program lead of Social Work Health Futures Lab, funded by the Robert Wood Johnson Foundation, and research fellow at the Institute for the Futures, who will take some time to get us to think in that way. We're also joined by Dr. David Murray, Associate Director for Prevention, Director of the Office of Disease Prevention at the National Institutes of Health, who will get us thinking about how the NIH is beginning to think about these issues and support work around multi-level methodology. I say their names and titles up front because we want to take as much time to engage in conversation with them. So I'm going to get out the way at this point and allow Dr. Nissen to come and present. And she's going to address some priorities related to her initiative to bring futures thinking frameworks to the social work profession and engage you in a conversation to see how it aligns with our commitment to innovation and equity-centered system change. Dr. Nissen.
Hello, everybody. So good to be with you all today. So I'm here to suggest to you that the problems, strengths, and solutions that we see and work with as social workers and social work scholars are not static. They are alive, emergent, and about to get more complicated. Anticipating, preparing for, and engaging as many as possible in democratic forms of co-futuring, I believe is an ethical imperative for the profession of social work. We cannot just look around and look behind. We have to look ahead. So with that, I'm going to jump in. To be a social worker at this moment in history is to hold a great deal of complexity. We reliably and intergenerationally argue about whether or not we are a profession. That is not true of lawyers or dentists or pharmacologists or anybody else, but social workers, we do. We argue about it. We are, but we argue. We contribute powerfully to well-being and the evolution of social welfare and social justice, but we have also, as a profession, lost our way, worked out of white saviorism, and we have failed to recognize the powerful and diverse membership in our history and ranks. We've also made some horrific missteps in our history, and we can never stop learning about them. Never stop. So what is the future? Let's get our terminology right. It's a personal, social, cultural, and politically contested idea, abstraction, with very diverse expressions, aspirations. It's a space that humans have long been fascinated about. Hello, Star Trek. Full of paradoxes. The future is fast. The future is slow. The future is surprising. The future is not surprising. It's always fuzzy. There are no future facts. The future is plural. There's always more than one possible future, even though there are powerful forces always asserting what is and is not possible, plausible. Futurists use a term VUCA, volatile, uncertain, complex, and ambiguous. And if that's familiar to you, it's because you understand what it is to live. Most universities are volatile, uncertain, complex, and ambiguous. There's actually a very famous Futures article that just came out about how COVID is the perfect storm. It is a volatile, uncertain, complex, and ambiguous pandemic. Futurities and imaginaries beyond the colonial gaze are part of the future. Afrofuturism, indigenous futurisms, decolonial futurisms. These all take up space in the idea of the future. But the future isn't just an idea, it's also a set of feelings. I'm going to reveal my age and lean in to read this. I just want to read this to you. Futures are many. Every epoch has its futures. Every place has its futures. And within each place and period, different groups and perceive different futures as they experiment with different hopes and fears. Futures are not only rational projects, but emotional experiences. They're not simply a matter of rational choice. They're made up of images, aspirations, and anxieties, some of which are unconscious and escape or resist rationalization. To futures, there are both explicit dimensions above and below the waterline and implicit ones, and not all that is implicit can be made explicit. Logic and plausibility play a part in choosing futures, but so do emotional, aesthetic, and imponderable considerations. So a relevant question to ask is, what do futures feel like? The bulk of what we do in Foresight, in many respects, is to help people develop empathy for their own future self and for the futures of others. And I love that quote because it brings it to life. So foresight is the term that is used referring to this global community of practice. It grows out of future studies. There are transdisciplinary methodologies that have grown up over the last 60 years, ways to study the future, explore ways of understanding the anthropology of the future. It has a very broad family tree, but there's always been a liberatory channel focused on the desire for futures of unlimited human potential, equity, and peace. Out of future studies comes foresight practice, which grew out of informed by that school of knowledge, emerging knowledge, using these ideas to create imagination, perspective thinking, world building, and capacity to inform better decision making now. The point of all of these techniques and ideas is to help us make better decisions now, to give future generations a seat at the table. It's used globally by governments, corporations, communities in a wide array of applications. And for my part, I landed in a critical and participatory foresight space, what Richard Slaughter described as futures praxis. It involves a rejection of the futures asserted by powerful entities, which we call official futures, and strives for global democratization of future building as a core commitment. And at this moment, I really do want to recognize the principle of the 7 generations, first written in the Great Law of Peace for the Haudenosaunee Confederacy as an essential elder of futures thinking. And so I just want to invoke that and remind us that it certainly was not the colonized world that invented this idea. The colonizers in the world, I should say. So why should we study the future? Alternative futures have long-term consequences. Forward thinking is preferable to crisis management. I think we've all been there. Further transformations are certain to occur. The future is something we should be concerned with together lest we lose our ability to impact it. Unless we create the future, it will be created by others. And we are left in a position to be reacting to it. So there are 4 levels of kind of how we work. Most people enter a future space wanting us to predict things, but predicting is never what foresight is about. However, there are a lot of things we can do to avert disaster. So that's the first level. Often we say something bad is coming, how do we avert disaster? We scan, we acquire good information, we try to pull that together. I'm going to share something with you about that in just a moment. The next level of depth in critical and participatory engagement is plausible futures. In this level, you acknowledge and embrace deep complexity, recognize the web of drivers and influences on the future, and do a lot of power analysis. A lot of imagination is invoked as an essential ingredient to explore and consider a variety of futures. Experimental futures is when there's real investments made in making a variety of imagined futures real so that people can prospectively pre-experience in provocative ways, expand imagination, actively experiment with implications and choices via an ethics and equity frame. And then finally, the fourth level, the deepest level, is transgressive, disruptive, transformational futures work that challenge and deconstructs all assumptions about what is and isn't possible, might or might not happen, and who gets to decide and shape the future. It is in this space that we've been playing a lot in the lab. Another beautiful quote, to work on the future is to use and apply the most powerful tool we have at our disposal, imagination, the ability and willingness to imagine alternatives to reality as we know it, which is always the first step towards making different and better realities possible. Being open to uncertainty is not a motivational quote or meme, but an actual rigorous and quite exhausting practice that requires holding multiple possibilities simultaneously, being able to see connections between the possibilities and not retreating from the ache. The instruments to help hold such possibilities could include fiction, myth, narrative, poetry, cautionary tales, activism, as well as models and scenarios, which are all part of the process. So I just want to, I'm very inspired by a futurist named Leah Zadie, who says the only three futures issues that really matter are the future of technology, and particularly AI, the future of the climate, and the future of equity. So I just want to talk with you a few minutes about those things. When we talk about the future of technology and how it might impact or intersect with the future of social work, it's not one thing. This is just a partial list. When we say the future of technology, it's all of these things. And by the way, I see some of you snapping photos, and that's awesome. But at the end, I have a QR code, yay me, so that you can download all of these slides, and you can just relax and say, well, just hanging out. So it's great. But smart cities, big data, social media, app development, AI, data justice, yada, 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 Chat GPT I just added yesterday before this session. All of these are technologies that are going to be disruptive. They are neither utopian nor dystopian, but we have many decisions to make together about how and where they should be used or what we need to do to either lean into or resist them. AI, I think, is one of the hugest issues that social work is not paying enough attention to. I did a little scan on my blog. How does artificial intelligence intersect with social work practice right now? Artificial intelligence is already taking away decision-making authority from social workers all over the world. In terms of algorithms, whether they're in child welfare or criminal justice or insurance companies, making decisions for us. But that's just a beginning. We get virtually no training in how this works in social work. And it is causing us to have a deep erosion, I think, of our potential impact in the future. Not to mention the power of algorithmic racism. With emerging technologies, we might assume that racial bias will be more scientifically rooted out. Yet rather than challenging or overcoming these cycles of inequity, technical fixes too often reinforce or even deepen the status quo. The amazing writer Dr. Ruha Benjamin says, she calls it the new Jim Code, the employment of new technologies that reproduce existing inequities that are promoted and perceived as more objective or progressive, coded inequity, a digital caste system that preys on our naivete. If you take only one thing away from me today, go get the book Race After Technology. It is just an absolute must-read for every social worker. Race After Technology, Ruha Benjamin. Climate. It's not just one thing, it's many things with cascading, intersecting dimensions. And I want to just say one thing, it's also not a separate category from this. For example, I just read an article the other day about the future of the internet is going to be very complicated by this because a lot of the wiring, that's the wrong word, a lot of the wiring of the internet is underground in places that are going to flood or be on fire or other kinds of things. So our internet isn't particularly stable. We think of it being there. But climate, many implications here. And then the future of racism, biotech, artificial intelligence, and isms embedded, climate racism, the future of justice, safety, policing, the future of work, the future of the middle class, the future of financial security, the future of health. How will the future of racism evolve? I want to just say that particularly when it comes to technology and climate, we continue and persist in social work, I think, in treating these like specialty practice areas rather than really seeing them for what they are, which is fundamental changes in the ecosystem of social work in the future. No area of social work practice, none, I would give you $1 million in this moment to give me a type of social work practice that won't in some way be impacted in a significant way by climate and tech. It's also a future of social movements that are blossoming, and I'm going to talk about that in a second, but social movements are a huge driver in the future of our profession. So what is the future of social work? For one thing, I just want to say, and I'll underscore this in a minute, the future of social work is way bigger than social work. It isn't completely like all about things we're going to do or not do. The way the world changes will impact what we do and how we operate. For one thing, we are not giving up on utopia. And in Foresight, we balance a use of utopias and dystopias. There's hard stuff to look at, but there's also beautiful stuff to look at. So in Foresight, there's an ethic to really making sure you do both. But the future of our profession should not be giving up on utopia, those places, spaces, and ideas that inspire and fuel our work. We honor places where that change is happening. But the future of social work is also about real-world challenges inside and around the social work profession in this moment. Our fissures, our trespasses, our crumbling bits. And they're real. They're not going to go away. So the future of social work is connected to those. But it's also connected to areas of progress in our profession, things we've fought for, things we've evolved, structures we've changed, and true impact that we're having in the work that we do. Finally, the future of social work is really about risk and issue palooza, the global threat landscape. What about cybersecurity? What does the future of cybersecurity have to do with social work? Well, it has a lot to do with the future of the world and the future of humanity. And of course, that's going to impact us in ways that we can understand now and ways we can't understand. So the future is all these things. Don't worry about this. You may not be able to read all these slides, but I have a handout on the QR code that you can look. I put together some questions for social work to be asking of ourselves. What are we resisting? What are we embracing? What are we regulating? What are we improving? What are we wasting time on? And I think a series of really important questions to do a reality check as we transition into the next era of our profession that will be very different than previous eras, very different. I think that the future of social work is really comprised in these 5 spaces: the future of social welfare and welfare ideologies and practices and structures, the future of social movements. When people say, what's coming next? I say, look to the social movements. What are social movements doing? What are they teaching us? What are they telling us? What are they insisting upon? The future of social issues themselves. Will AI, I have a new article about which I sent out to the fellows. It's a really funny / horrifying article about a new AI system called Big Daddy, and 20 years from now, a giant algorithm that actually is the central government of the United States. Will government by algorithm be a future issue? I don't know, I hope not. I won't be voting for that if it counts. But nonetheless, could it be? Can an algorithm be elected on your city council, whatever? And we already know, by the way, that there are some AI-guided lawyers. There's new stuff out about that. So you can get a little earpiece. There are not enough lawyers, so you can go into court, have a little AI lawyer, put in a headphone, and as the thing is going on, the AI lawyer will advise you. The future of racism and all forms of equity. And then all of those lead to the future of the social work profession, and by the way, the future of professions in general, which are changing very rapidly. Each of these things has a past, a present, and a future, and their intersection, I think, very much comprises what the future of what we'll do will be. This is a game that I put together called Social Work Jobs of the Future. You can find it on my website, in which I use signals of the future that I found to imagine what social workers might be doing 20 years from now. They're things like reparations agent, or an elder care robot calibration specialist, or a political cult family deprogrammer, an immortality consultant, a heat advocate and coordinator, an eco-grief anxiety specialist, a climate refugee resettlement counselor, a digital death coordinator, a space earth adjustment coach. And there's many more. And I invite you all to play the game along with me. How am I doing? Okay. Because I'm here at SWR, I thought for your enjoyment, I would do a little horizon scan of the future of research. And I happen to have a dear colleague whose husband works at the National Institute of Science, or National Science Foundation, rather, and I shared these with him and vetted them, and we had a great conversation. Just a few things. I'm going to run through them quickly. What is the future of research? How do we use futures thinking to imagine what that might be and how we'll take our place in that? I found signals related to such things as a rise in chatter about academic capitalism and also endangered scholarship, scholars who literally are putting their lives at risk to study certain things or at least going to jail. Queering research for critical feminism, qualitative and quantitative methodological advances that are happening, faith in science declining among Americans. That's going to shape a lot of the future of the research that we're able to do. This next one's huge, big data research futures. So we're starting to see sort of a quantum capability to use big data for research. And I think that can be really good in a lot of ways, but can also really marginalize every other kind of research. So as this kind of research starts to take on a kind of credibility and importance, it's going to marginalize other kinds of research, and I believe take up more and more resources. So that's a concern we should be looking at. How do we begin to boost and amplify research that is not big data oriented? Will people start to perceive it as not being as good or effective? We already have challenges around that. Trends showing less disruptive impact in research over time. There's a brand new article out in Nature, I don't know if anybody's seen it, that somebody did, 70 years of analysis of scientific research, and this is related to academic capitalism, showing that we're producing science in general, more research than ever before in history, but less disruptive research. So it's the impact of publish or perish. We're compelled to do it, but we're not taking very many chances with it. Decolonizing research, which is a beautiful historical realm, but has had some wonderful modern rebirth. Citizen science is actually a big deal. How can citizens be involved in co-creating science and participating? Trauma-informed research. The ethics of collaborating with big tech for research. Should Google sponsor our research? What do we think about that? How's that going to work? Slow scholarship and critical digital scholarship, so the idea of resisting big data dominance, and so that may be a place we wish to align. These are important, they're interesting, and the thing about landscape scanning is it's never done, it's a practice. In general, foresight is not infotainment, it's not a one-time event, it's a set of practices. And I believe that as social work, we need more and more spaces and places to practice together and learn from each other. So I have been asking for the last 5 or 6 years, what would happen if a social worker became a futurist? So that happened, and I no longer cared if anyone laughed, I was gonna do it. But then I talked my good friends at the Robert Wood Johnson Foundation into funding a national lab because we have no such space to explore the utility of these tools and these ideas in social work. We needed a space, we needed a lab to play with them, to learn with them, to interrogate them. And so the Social Work Health Futures Lab was born. I don't have a ton of time. I would love to read everyone's name, but I do have just two of my fellows in the room. So Danielle Littman and Juan Rios is here. So just want to give a shout out to them. For the last 2 years, we had a wonderful National Advisory Committee. We selected 26 people. We constructed a shared statement of values and how to steer ourselves through this. We did foresight training, thank you. We learned from guest futurists. We played games, applied tools, engaged in cross-sectional explorations, and we used the lab as a sounding board for our crazy ideas. Our lessons, and there's on the page I've prepared for you is our whole final report, are really the importance of relating, navigating, creating, and complicating the idea of the future as we engage in these spaces. So I just want to invite you all, as we finished up our first leg of this project, we just got a second grant. About a year and 2 months from now, we're going to be doing a Social Work Futures National Conference. It's going to be completely online. We're still debating on whether or not it's going to be from the future, or which would be interesting. Because in general, when you go to futures events, they kind of blow your mind on purpose, and that's good. But please follow me at Laura Nissen on Twitter for as long as it's there, or the Social Work Futures Lab for updates about what happens next. We will have a Slack channel. We're going to open up, in addition to the conference, the lab nationally. So any social worker or social work scholar that wants to get involved and start playing with us, start learning about these issues, we are ready to sort of throw open our doors and welcome you into our community. I'm going to have a book, God willing, in 2024 called Anticipatory Social Work, Foresight-Based Tools for Social Imagining and Collective Praxis. Shout out to Oxford University Press. And the last thing I want to say is foresight is not an event. It's a skill, a process, and a capacity, building collective intelligence, collective imagination, collective agility. Again, I believe that it's an essential time for social work to look towards the future in a different kind of way. Go beyond the word, the future, because just saying the future doesn't mean we're actually prepared for it. And just because we've thought about it doesn't mean we're actually prepared for it. It's actually a rigorous application. Last thing I want to just say, we're having kind of a spontaneous, thanks to Dr. Juan Rios, we're having a spontaneous futures game situation tonight in Encanto B. Dr. Rios bought futures games, and if anybody's around and you want to come join us, in Encanto Room B, we're going to play some futures games and have some fun. So, thank you. Oh, at 7. Yeah. Thank you.
Wonderful. Wonderful, wonderful.
Oh, sorry. I got to do one more. Pardon me. It's coming. There it is.
Look at all the phones. So as you've seen, there's a theme that emerged, and sometimes faith brings things together. From the opening plenary about imagining, right, alternative realities and whether or not we work towards them, to being encouraged now to be true futurists, right, and how we advance our work, knowing that there are key priorities that we can advance. You know, for me, I hear it very clearly. I know the environment matters, but of course, I'm thinking about the equity issues. But again, I want to thank you, Dr. Nissen. Again, we'll hear from our next presenter, and then we'll have time for questions and answers. So at this point in time, I'm trying to keep notes in the future, well, present day way. I want to now introduce Dr. Murray. As I mentioned, he's the Associate Director for Prevention and Director of the Office of Disease Prevention at the NIH. Dr. Murray will be joining us remotely, and we really appreciate this opportunity to begin to forge a relationship between our society and for him to know more about what we do as social workers. And that was my original approach to meeting Dr. Murray, but he's like, I know social workers. And he has a strong relationship with those at University of Washington. But again, Dr. Murray, thank you for taking time, and we will allow you to go at this point in time. Dr. David Murray.
Thank you. I'm very happy to be here, at least virtually. I'm sorry that I can't be with you in person. I want to talk with you about NIH efforts to improve health equity through rigorous research. And not just talk about it, but invite all of you to participate in this process and invite social work professionals who aren't at the meeting to participate in the process. Let me say just a few words about my office, the NIH Office of Disease Prevention. We're located in the Office of the Director, so we're not part of any given institute or center at NIH. We work with all of them. We're not focused on a particular health outcome or a particular risk factor. We work with all of them. Our mission is to improve the public health by increasing the scope, quality, dissemination, and impact of prevention research supported across NIH. We follow a strategic plan. We have 7 priorities in that plan. I'm certainly not going to go through all of these, but we're going to focus today on number 3, as it turns out, improving research methods, and number 7, addressing health disparities. So, in our work looking at how NIH invests its resources in prevention research, we've determined that about 24-25% of the NIH budget is used for primary and secondary prevention research in humans, and that pattern has been pretty stable over the last number of years. We found that only 1 in 3 of those projects measured any of the leading risk factors for death and disability in the US, as defined by the Global Burden of Disease Project. We found that only 1 in 9 of those projects involves a randomized intervention to address a leading risk factor. And most frustrating to me, only 1 in 19 used an intervention to address a leading risk factor in a health disparity population. So that means that right about 1% of the total NIH budget has been used to support intervention research to address the leading risk and protective factors for death and disability in the US in populations that face health disparities. That's not much, in my view. Now, why am I so interested in the leading risk factors? Well, they're very much related to death and disability. The leading risk factors account for 74% of the variability in county level life expectancy. In this figure, you see lower levels of life expectancy in red and higher levels in blue. And the red areas are certainly concentrated in the Southeast, but you find them all over the country. The associations among SES, race, ethnicity, and life expectancy are largely mediated through these risk factors. Certainly, the social and structural determinants are significant contributors. My office proposed early last year, an initiative that we call Advancing Prevention Research for Health Equity. It's an NIH-wide effort to develop and test new interventions and to develop and test new strategies to disseminate existing interventions, all of which address the leading risk factors for death and disability in health disparity populations. This initiative is driven and supported by the participating institutes and centers. My office serves as the coordinating group. The concept was approved by the NIH Council of Councils in May. As we have come together to think about how we're going to approach this, the participating institutes and centers have identified 4 focus areas: cardiometabolic, alcohol, tobacco, and other drugs, cancer, mental health. So we have working groups in each of these 4 areas, and they're charged with developing funding opportunity announcements for new research to develop and test new interventions or develop and test new strategies for dissemination of existing interventions. All of the funding opportunity announcements will share these features. They'll all focus on NIH designated populations that experience health disparities. That includes racial and ethnic minorities, sexual and gender minorities, socioeconomically disadvantaged populations, and underserved rural populations. These are all populations that you have experience with. Other priority populations are included in combination with these 4. All of the funding opportunity announcements will support prospective preventive interventions, either focused on primary or secondary prevention or universal prevention. They'll test new interventions or new implementation strategies. They'll use experimental designs or rigorous quasi-experimental designs. Very importantly, each of the projects that we will fund out of these funding opportunity announcements will need to collaborate with community partners and service providers to enhance the acceptability, feasibility, and sustainability of the intervention. And they'll have to do that from the very beginning, not just after the project gets funded. We anticipate that these funding opportunity announcements will support multi-level interventions addressing social determinants of health that go beyond individual levels of knowledge, attitudes, and behavior. We published 4 notices in 2022. As often happens in these circumstances, in order to put money out on the street quickly, we used administrative supplements originally. That announcement has expired, but we have 3 others that are still in place, and they're identified here. They'll support, the first one supports an RFI, request for information. The other 2 will actually support grants, whether R21s, R01s, or the other mechanisms identified here. and focused either on uptake of evidence-based screening or preventive interventions to address cardiometabolic risk factors. Additional funding opportunity announcements will be published in 2023. Unfortunately, I can't talk about them until they're actually published. So this is the set of 4 that I can talk about that have come out of advance so far. Let me turn and talk for a few minutes about our methods work and our efforts to improve research methods. As I said, we anticipate that these funding opportunity announcements are going to involve multi-level interventions. These are now widely used to address the leading risk factors for death and disability in the U.S. They address factors across multiple levels of influence, and their evaluation requires study designs and measurement methods and analytic methods that reflect the multi-level nature of the intervention. Interventions are often either randomized or otherwise allocated to clusters of some kind. We may assign schools or workplaces or health clinics or neighborhoods, whole counties. Rigorous study designs include group or cluster randomized trials, step wedge group or cluster randomized trials. These are randomized designs that I've worked with for 30 years now. There's a very strong methods literature in this area. And I want to encourage social work schools and programs to provide training to their graduate students in these methods. These are the most rigorous methods available to evaluate multi-level interventions. In the non-randomized side, we have regression discontinuity designs and interrupted time series designs with appropriate comparison groups. These can be very strong designs, especially the risk regression discontinuity, and we certainly will consider applications that employ these designs in response to the funding opportunity announcements. It's also important in this research to use measures that address the multiple levels involved in the interventions. So measures beyond the individual level to include, for example, family or interpersonal level, organizational level, community level, societal level. All of these measures are important. NIH has a number of resources that we provide to anyone who wants to take part of them. My office provides a 7-part online course in pragmatic and group randomized trials in public health and medicine, and you see the website link here. This is obviously self-paced since it's entirely online. You can take any part of it at any time and in any sequence, and it covers group randomized trials, or also called cluster randomized trials, as well as individually randomized group treatment trials. There is some material on step wedge designs, and we're going to be adding more material on step wedge designs this year. We provide a research methods resources website at NIH, and this includes information on broadly applicable methods. It's about 20 methods that are widely used in clinical trials that are supported by NIH, methods for trials that randomize groups or deliver interventions to groups, and that's going to include an awful lot of multi-level intervention studies. We provide background information, key references, and in addition, sample size calculators for the 3 most commonly used designs for evaluation of multi-level interventions. So there's a sample size calculator for step wedge, a sample size calculator for individually randomized group treatment trials, a sample size calculator for parallel group randomized trials. These sample size calculators include built-in tutorials. So if you don't know a lot about these designs, take one of these calculators out for a spin. And if you read through the material, you will learn a heck of a lot about these designs. Lots of references. We provide formulas and worked examples in addition to downloadable results. And you can copy and paste materials right into grant applications. The Methods Mind the Gap webinar series, sponsored by my office, presents a webinar almost every month, exploring research designs, measurement methods, interventions, data analyses, all methods used in prevention science. The next one happens to be coming up on January 24th, titled Transparent, Open, and Reproducible Prevention Research. Following each webinar, and you can find them at the website located here. Registration is required, but it's free. And about a week after each webinar, you can download the slides and the Q&A materials. Our office does not provide the Phoenix Toolkit, but it's a product that's made available by NIH writ large. This is a catalog of perhaps 900 or so recommended standard measures to be used to measure health and disease, various traits, exposures, and it can be any of these can be used in biomedical research. It includes multi-level common data elements for research on social determinants of health. And these common data elements, which we widely recommend to people, make it much easier to compare results across studies, to do pooled analyses across studies, and to do use meta-analytic methods. As I said, there are about 900 measures included in the Phoenix catalog. Opportunities for the society and for social work writ large. I've said that the ADVANCE project has released several funding opportunity announcements this year and will be releasing more in the coming years, but that's just a small slice of what's going on. NIH has really focused substantial resources on structural racism, discrimination, health disparities, structural determinants of health, multi-level interventions, and related topics. This has exploded in the last 2 years. And if you go to the NIH guide for grants and contracts at grants.nih.gov/search guide, you'll find hundreds of notices and funding opportunity announcements in these areas. And you can search to your heart's content and find announcements that are could support the work that you're interested in doing. So I encourage all of you to use these tools to find funding opportunities for your work. I also want to encourage you to provide training to graduate students in social work in 2 areas: design and implementation of multi-level interventions, since those are the kind of interventions that are going to be most helpful in addressing health disparities. I mentioned one very recent book, I think it appeared in August or September, from Dr. Leslie Lytle at the University of Minnesota, Designing Interventions to Promote Community Health, a Multi-Level Stepwise Approach. That is just one such resource on designing multi-level interventions. There are lots of resources on designing analytic methods for evaluation of these kinds of interventions, and I mentioned a few of them earlier. The online course on designing, analyzing group or cluster randomized trials, the Mind the Gap webinar series, and the Research Methods Resources website that has lots of information on these and related methods, and encourage you all to take advantage of those resources. That's the end of my formal presentation. These slides are in the hands of Jennifer Lewis, and she can make them available to any of you who would like to have them. That will certainly make it easier to use the links that I've cited in the presentation. You can always send an email to our office if you're interested in more information on any of these issues, or an email to me at odpdirector@nih.gov. I thank you very much for your attention, and I'm happy to participate in the Q&A at this point.
Thank you very much, Dr. Murray. So you were given this continuum to think about in between beginning to imagine, right, different futures with different priorities that was set by Dr. Nissen, and to the very practical implementation of how we advance one form of science, which for us is intervention work and intervention research. And in between those 2 continuums gives you an opportunity to say, now, which part of this do you want to pick up? You heard a call for training. You heard a call for additional methodologies. You heard a large call for solutions. And this begins, I'm hoping, a conversation that really pushes to say, let's not leave it for another generation of social work scientists to deal with these issues, right? Let's try to offer some solutions. So I'm going to stop, and we're going to take some questions for the next couple of minutes, because you have 2 wonderful individuals to be able to speak to. So again, the mics are here, and please, if you'd like to ask a question, please step to the mic and say who you're directing the question to at this point in time. Yes.
Hi, good afternoon. I'm Margaret Lloyd Seeger at the UConn School of Social Work. Dr. Murray, thank you so much for your really nuts and bolts presentation. In my experience, one barrier to accessing NIH funding is that social work hasn't always been a discipline that has accessed NIH funding, and it seems to be sort of a funding begets funding type situation. So I know there are opportunities for new investigators, early career investigators, et cetera. If you could just talk a little bit about that, just to increase accessibility and open the door to social work scholars doing a lot of the work that you are interested in.
The advice that I would give anyone, whether social work or another area, if you have not had NIH support previously, the best way to get that going is to collaborate with somebody who has. Partner with someone else at your university, at your institution, who has some experience with that, and bring the social work issues into the project in partnership with the other people who have more experience with NIH research. I think it would be quite challenging for any of you or anyone in another area who hasn't done NIH-supported work before to simply start on your own and try to write a grant application and submit it to NIH and hope to get it funded. That's the hard way. So I want to actively discourage that. Far better to find collaborators, whether they're in psychology or in medicine or in public health. You're going to find people in those areas who have substantial NIH experience and may be interested in some of the same issues. NIH supports research that has health outcomes. So medicine, public health are natural areas for that. And people in social work can collaborate with them. Now, that may mean that you're not the PI on the first project, but as you get more experience and learn about it, you can start to spin off and develop your own things. There are also plenty of people in social work who have substantial NIH funding records. I look at the University of Washington program in social work where Rico Catalano and David Hawkins had amazing careers supported by NIH. And have left a group behind, since they're now largely both retired, left a group of younger folks behind who are continuing that work at UW. And there are going to be other examples like that.
Thank you. Yes.
Hello, thank you for both of your wonderful presentations. Dr. Nissen, I'd like to ask you, you said that corporations and politicians have been doing this for a long time and they pay futurists to kind of think about how to keep their powerful interests going. And so I appreciate the fact that you want to create a lab with future for social workers, but do you think that that has to be in opposition or alternative to those things? Or are there ways that we could take where IT and mobility and some of these corporate interests are going and have social work be parallel to that in a way that we can benefit from the work that's already been done and also complement it as opposed to always being oppositional?
Well, I think it's a really good question. Thank you for that question. And I think those are things we need to figure out. Amy Webb, futurist Amy Webb, has a book called The Big Nine, and it's about the big 9 tech corporations. 3 in China, 6 in the United States, you know who they all are. Her point in that book is that the future of humanity really is being decided by 9 corporations behind closed doors in non-democratic ways. And that part of the reason we want to push out this toolbox is to say, I don't think any of us want that, right? We do not want the future of humanity decided by 9 corporations. So it's not all one thing. I think there are some things that we may want to decide that we're actively wanting to block or interrupt. In my hometown of Portland, Oregon, the whole city just rejected facial recognition technology as part of a smart city uptake, which big tech was in there saying it's the best thing ever. And Portland said, I don't think so. And then we became part of a international movement really of big cities rejecting facial recognition technology because it's racist. So there may be places where we actively want to go up against and places where we actively want to say this fits with ours, but it's that process of dialoguing, I think, which can only happen in transparent ways and by getting the issues out on the table. I do not think technology is either utopian or dystopian. It has features of both. I am not anti-tech. I love tech. Look at my QR code. I mean, I love tech. But I think social work is at risk sometimes of being techno-solutionist in terms of saying tech will not save us. Tech will not solve our problems. We got to be in there fighting for equitable, ethical tech. There are other professions that are, and I think we need to be with them. There's a whole tech justice movement that we need to be learning from and aligning with in ways that I don't think we are yet as much as I'd like. So I hope that answers your question, but I think both things. By the way, on my QR code, I do just want to underscore that the final report of the Social Work Health Futures Lab is on this page I prepared, and that is where you can go and meet all of our amazing fellows, which I want you to do because they're all incredible people.
Is there a question? If not, I do have one for Dr. Murray. The focus on health disparities and, again, multi-level interventions, that work suggests longitudinal level investment and it takes time to change those results. How's the NIH or your office thinking about that versus the kind of 5-year, sort of projects that an R01 is typically designed for when you're trying to do structural interventions or these broader social determinants of health? We'd love to hear about how you're thinking about that. All right.
Well, certainly part of what NIH is supporting is the traditional 5-year R01 in this area. But in addition, a number of the major announcements that we've seen in the last year, like the one from the National Institute on Minority Health and Health Disparities on structural racism, was a potentially 7-year mechanism. It's a UG3, UH3 paired activity code. Sorry, I hate to use the jargon, especially when I don't have a blackboard to write it on. The UG3, the first part of that, is a 3-year planning period. And it's a time when the team can get themselves organized and get the intervention developed and do pilot testing, a variety of other kinds of things. And then at the end of that, they could have another 4 years of support to evaluate, test the intervention. And so it is certainly possible for a longer period of support. And even if you're doing something with a 5-year window, it's always possible to do renewals. One of the projects that I cut my teeth on at the University of Minnesota was the Minnesota Heart Health Program. That was funded for 13 years. It was 3 different awards consecutive, but it's certainly possible. NIH has lots of experience supporting longer-term projects and recognizes the need for that in many areas, and this is certainly one. Health disparities didn't develop overnight, and they're not going to go away quickly.
Thank you.
But they also won't go away without effort, real effort.
Hello. So I have a question for you, and that is, how are you all at NIH calculating the potential impact of catastrophic climate change disruptions and rapid tech evolution and proliferation into your long-range plan? So what is the future of NIH? How will you be, as an institution, responding to and engaging with these two dynamically jolting and disruptive kind of issues in the coming years? Any thoughts about that?
I can't answer the question in full by any means. I won't try. But I can say that there is an awful lot of interest in climate change issues here. That is not something that NIH has traditionally worked in, but it is getting a lot more traction in the last 2 years than it did before that. In terms of big data and tech, there's a heck of a lot of interest in big data and what big data can do, especially in terms of developing better treatments for health conditions or preventing health conditions. I'm not sure that NIH is focused on some sort of a potential disaster that big tech might create. I think the work here is more on how can we harness the power of big tech and the power of big data to make advances in biomedical research.
Yeah. Thank you. And I know, yes, one last question, and I think, Rick, you will be it.
One of the things that social workers have been doing for a long time is collaborating with state partners to work with administrative records, birth records, child abuse reports, emergency room admissions, and so on. So it's big numbers, but it's low quality measurement. And you're mentioning all the recommended measures that NIH has now available to us. But there's this gap between what we're able to have access to in terms of looking at public health effects and the quality of measurement. And I'm just wondering if you have any thoughts about how we could build on that history of work with administrative records to be more helpful to NIH-type intervention, multi-level interventions like you're discussing.
NIH has long supported research that's used administrative records of many different kinds to help evaluate the projects. There are any number of studies supported today based in healthcare systems where the unit of assignment to intervention or to control is a clinic or a department or a hospital or a physician's practice. And then the interventions are conducted sometimes with staff in those organizations, sometimes with the patients, the participants directly. And many of the data then are drawn from electronic health records. They're not based on the Phoenix measures. I offered that as one example, but many of these studies evaluate their interventions using data that are readily available that the hospitals are already collecting that are part of the medical record. There are many other kinds of studies where we've used state data. The classic example that I always talk about when I taught these methods with time series was looking at the impact of state changes in the law related to age of use of alcohol or age of use of tobacco, and looking at administrative records to help evaluate those kinds of interventions. So you don't always have to have the most sophisticated, most complex measures. We can learn a lot using data that are very readily available.
All right, that concludes our session. I want to give thanks to Dr. David Murray. Thank you very much. Dr. Laura Nissen, thank you very much. We look forward to continuing to engage with you. And I thank you all for attending. Thank you.